President CSI in the past. Okay, so the anti-thrombotics in the management, we all know that for doing coronary interventions especially, you need profound inhibition of platelets. This is usually done by using aspirin in all the patients, and in most patients, again, a P2Y12 receptor antagonist. Usually these drugs which are used are oral drugs, and one moment, let me just make this smaller. Okay, yeah, and so the cangrelor comes into this area that is also a P2Y12 receptor antagonist and is going to compete for the space with the other drugs, not exactly compete, but is going to work along with the oral antiplatelet agents. Okay, so what are the limitations of oral P2Y12 receptor antagonists, the clopidogrel, prasugrel, or ticagrelor? There are situations where it is not always feasible to use these drugs or depend entirely on these drugs. These situations are like cardiogenic shock, patient is heavily sedated, patient is mechanically being ventilated because he has just come out of a cardiac arrest, patient is having nausea, recurrent vomitings where you do not know whether the drug will be absorbed or not, and there, for the same reason, there can be delayed bioavailability. So with all these things in the background, the drug is either not there in the gut, or the drug, even if it is there, it might have been vomited or is not getting absorbed due to poor circulation. In fact, 64% of all STEMI patients with cardiac arrest are unconscious during initial evaluation, and one may not be able to give this drug. So the limitations of oral P2Y12 receptor antagonists, which I mentioned, delayed drug absorption. In addition, there is a delayed onset of action. Even if you give this drug, one of these three drugs, the drug may not be absorbed and or maybe absorbed in a delayed fashion. It may take 4 to 6 hours or 2 to 4 hours, depending on which agent we are talking about. And therefore, the adequacy of platelet inhibition may not be there while you are about to do angioplasty. These drugs, especially prasugrel and clopidogrel, are irreversible platelet inhibitors. And in case you have given these drugs and you want to send the patient for surgery for, let us say, you change your mind after doing the angiography, or a patient developed a complication and has to go for surgery, the irreversible platelet inhibition can actually be a problem and can lead to bleeding following surgery. So there is an area where one may think of a intravenous drug, where this drug is capable of inhibiting platelets within no time, and at the same time the action is reversible, and in case you want to take the patient for surgery, you just can stop this infusion and the drug's action will disappear in a short time. So cangrelor really falls into this kind of scenario. It is a very fast acting drug. It is an intravenous agent, and the moment you stop it, within about half an hour to 45 minutes, the drug's action disappears. And when it acts within no time, in 2 to 4 minutes, and it inhibits platelets extensively. Okay, historically, the intravenous agent which has been tried in the past is one of the glycoprotein 2B3A receptor antagonists. These drugs have become very uncommonly used nowadays in most cath labs. With the advent of prasugrel and ticagrelor, we hardly use, I think in the last several years, we have hardly used in more than one or two cases, not more than 1 or 2 cases of GP inhibitors. If today we use it in those cases where there's a large intraprocedural thrombus burden, slow flow, no reflow, etc. The problem with the GP inhibitors is the high incidence of bleeding complications. Okay, cangrelor is short half-life and rapid onset and offset nature is seen as a novel benefit, especially in those patients who would go for cardiac surgery for one reason or other. So cangrelor falls into this kind of situation where it has got all the ideal characteristics. Let us see what its pharmacokinetics are. This is a highly bioavailable drug. There is hardly any drug-to-drug interaction. The onset of action is within 2 minutes, and it's a highly potent drug. It inhibits 95% to 100% of platelets which are there in the circulation. The offset of action is also very fast, 30 to 60 minutes, and no dosage adjustment is required in patients with renal or hepatic impairment. Naturally, a comparison with the oral P2Y12 receptor inhibitors is in the order, whether it is clopidogrel, prasugrel, ticagrelor versus cangrelor. Cangrelor's action is reversible like ticagrelor. It is not a prodrug. It is it's a directly acting drug like ticagrelor. On the other hand, clopidogrel and prasugrel are prodrugs, and they take some time for absorption and bioavailability for that matter. The half-life of the parent drug is 3 to 6 minutes with cangrelor, and there is no active metabolite which is available. The administration route is obviously intravenous, and it is given as a bolus plus infusion in most cases. Onset of action is 2 minutes and offset of action 60 minutes. And the ESC has given a guideline that cangrelor may be considered in P2Y12 receptor inhibitor naive patients. What it means is that if for one reason or other oral antiplatelet anti-P2Y12 receptor inhibitor has not been administered, such is the situation where cangrelor may be considered. The other guidelines almost are similar. Efficacy and safety of cangrelor in patients undergoing PCI, clinical evidence. Okay, here this is a real-world analysis, and they studied cangrelor in about 500 patients and GP inhibitors in about 1,500 patients, and it shows that the bleeding complications are definitely significantly less with the usage of cangrelor compared to glycoprotein 2B3 inhibitors, and even the all-cause mortality, cardiac mortality, myocardial infarction, CABG, all of them are less commonly required with cangrelor. But this is a real-world study, not an exactly randomized study, and you have to take it with a pinch of salt. Okay, now here, this is a, you have got a three trials, the champion group of trials, champion platform, champion PCI, and champion Phoenix. And let me go take you through these important studies. The champion platform randomized about 5,000 patients to IV cangrelor versus placebo. But the important point here is the clopidogrel is the drug that is used in both the arms, but that was used after the cangrelor infusion is over. Now, that makes it a little difficult to understand what happens to the placebo group where angioplasty is being done. He is neither on cangrelor nor on clopidogrel, and that makes it a little difficult for me to accept the study with all this knowledge which we have today, that P2Y12 inhibition is very important for prevention of stent thrombosis. Anyway, this particular study has shown that you can see here both the groups received clopidogrel 600 milligram after PCI, and you can see here that cangrelor actually the primary occurrence was less commonly seen compared to placebo, but it is only numerical and it is not statistically significant, and the study is considered as a negative study. Now, similar thing you can see here, the results are not really statistically different between the two arms, the placebo and the cangrelor. And among patients undergoing PCI for NSTEMI ACS, the use of cangrelor reduced the primary outcome, but this is only numerical. This particular champion platform, almost all the patients were ACS patients, but most patients were NSTEMI patients. Okay, then came the champion PCI trial, which randomized about 8,000 patients, and this has randomized patients of stable angina, unstable angina, and STEMI are a minority, and the entire spectrum of PCI have been randomized in this. And here, once again, a cangrelor is given as a bolus as well as infusion. And what do the results show? Here, in fact, the champion PCI, the results are worse with cangrelor. Now, once again, here, clopidogrel is given after the PCI is over. Is that small time difference between stopping of cangrelor infusion, after which the action disappears, and then the onset of action of clopidogrel takes time? And is that time window responsible for this? We do not know. But the fact is that the results are not encouraging at all. Then came the champion Phoenix trial. And this one has, of course, randomized 11,000 patients, even bigger group. And this happened to be a positive trial. At last, they got the point. And what happened here is that they have randomized most of them, again, ACS patients. And they used aspirin as well as cangrelor versus clopidogrel. And they gave here clopidogrel somewhat early compared to the other two trials. And here you can see that cangrelor compared to the clopidogrel arm has 4.7% of primary outcome versus 5.9%. And here this was statistically significant. And you can see here the same thing applies to stent thrombosis, definite stent thrombosis, MI, and ischemia-driven revascularization. So with the combined pooled data of all the three trials, when it is pooled, it shows that Cangrelor scores over the standard therapy, and death, MI, urgent revascularization is significantly less compared to the placebo arm, and stent thrombosis also is less. So with this data, let us also look at the a mechanistic study, which you can call it as a mechanistic study, because they just took a small number of patients and looked at the degree of platelet inhibition in this Cantic trial. And here they have taken 44 patients and they randomized them to ticagrelor, cangrelor in one arm and placebo in the other arm. But both the arms, they have given crushed ticagrelor 180 milligrams. So here ticagrelor is given right at the beginning of the PCI, and that's a very important difference between the other trials and this. And what happened to the platelet inhibition? Here you can see the green line shows that there is a significant inhibition of platelet agglutination in the cangrelor arm. And in the other group, where there is only ticagrelor, the inhibition took some time to really manifest. Therefore, adding cangrelor clearly is an advantage over and above just giving ticagrelor. And that's a point which has been repeatedly emphasized, that if you want to give an oral 2B3 oral P2Y12 inhibitor, the drug that should be combined is ticagrelor and not clopidogrel or prasugrel, because these two drugs, by a peculiar mechanism, they just won't act if you are giving them along with cangrelor infusion. You can see here that clopidogrel, if you want to give, you give it after discontinuation of cangrelor. Prasugrel, once again, after discontinuation of cangrelor. Ticagrelor can be given anytime during cangrelor infusion. You can see here, the take-home message is, therefore, the most definitive indication is a case of acute coronary syndrome, especially STEMI, going for primary PCI, where patient cannot wait for oral P2Y12 antagonist to take effect. The oral antiplatelet to accompany it is ticagrelor for reasons which have already been alluded to. Thank you.
I have one question. See, I don't have an experience of using this, but still, see, now you have first shown the group of people where you cannot give oral P2Y2 inhibitor, the group of people, subgroup of people, where you use this molecule. Can we give GP2B receptor blocker in such patients for even 12-24 hours, and then we can give this through RILES too? In which subset of patient you see this is definitely useful?
No, you are right. All these days, that's what we have been doing. If we are afraid that the antiplatelet action of the oral drugs is not adequate or cannot be depended upon, we have been using glycoprotein 2B3 inhibitors. There's no doubt. But now this drug has come. Now this drug has been shown in real-world experience to have lesser chances of bleeding complications. And GP inhibitors, we know that in most studies where you have been studying, we know quite a bit about GP inhibitors. The bleeding complications are clearly due to GP inhibitors, significant incidence of bleeding complications. That is not seen with cangrelor. Now, whether this will really turn into real-world experience, see this drug, nobody used it in India because it is not yet released here, but it is going to come, So we'll all probably gain experience. We will know about it.
Thank you.
This is for patients in whom you do not know whether the drug is absorbed or not, oral drug. So to make sure, you can give an intravenous P2Y12 inhibitor.
Thank you.